Some people have rationalized it like saying it decreases the stress to other organs, which there's papers in critical care that say that's not necessarily the case. And this is controversial. We can argue till cows end. And symptom relief, probably I would give that as the biggest one, to be quite honest. But slap somebody on oxygen, tell them to sit it out, I wouldn't transfuse them. So those are your basic benefits of transfusing. Now, let's go through the bad things. So blood in and of itself is a huge iron load. And I've actually seen patients that have had so much blood transfusions that develop this condition called hemochromatosis, where all that iron starts depositing in all their organs. And ironically, when it does so in the bone marrow, you get anemia. So then they give them more iron and more transfusion and so on and so forth. And this goes unrecognized a lot of times. Patients with renal failure, all blood, after about a couple of weeks, starts becoming more fragile, and it's more willing to break and release everything it has inside. And one of those things is potassium. So if you have somebody with coronary disease, heart failure, kidney failure, you don't want to be giving them a bunch of potassium. Intrinsically, it's a volume, and there's people that cannot handle volume. So it is not uncommon to see people that get a certain amount of blood, and then they're put into respiratory failure because their lungs are filling up with fluid. So the biggest thing for me that goes unnoticed is that you get a blood transfusion, and I'll go through these slides shortly. You will effectively decrease your ability to fight infection, and you will raise your chances of getting an infection. And I'll go through that in a bit. Just as a quick note, your chances of getting a hospital infection is about 4% in a hospitalization. That means you can leave with something that you did not come with because you were just sitting in a hospital bed. That goes up to 50% with one transfusion. Sorry, wrong finger, one transfusion. Which is pretty impressive. I mean, we were talking with Dr. Worthington about a cut in 6 to 9%. 50% in medicine is a catastrophe, especially when it's going the wrong way. There's my bad finger. So I like infectious diseases, so I'm going to talk about infectious diseases because I can. And so for instance, bacterial infections, you'll get 1 in 2 to 3,000 transfusions. And there's a bunch of bacteria. That's about 1,000 patients per year. Now, 1 in 1,000 units are actually contaminated from bacteria, and 1 in 500,000 will die. That's about 7 patients a year. Doesn't sound like a lot, but mind you, these perhaps are sicker patients that are getting already a lot of care. So in my ICU, everything we do is about cutting risks and tilting the balance to your favor. So if you're already sick in your own right with shock, why should I be tilting the balance in the opposite way if it's not going to change mortality? And that's the point that I'm trying to make. If you knew that I was going to give you a gun with a bullet, and you had a 1 in 500 chance of being you, who would actually pull the trigger? I don't know. Can we get the guns, please? Oh, just kidding. Everybody knows about HIV, Hep B, Hep C, but we don't know perhaps about dengue and West Nile, and we do have them here. We do see cases of dengue and West Nile. Prion disease, it's an exotic disease. It's called a spongiform encephalopathy, blah, blah, and you sort of get demented and die. So don't worry, you won't see that too much. But in the Caribbean, you do get certain parasitic infections from blood. And mind you, most of these are not tested for, and most of these are not tested for. So there's a certain element of a gamble. So all of a sudden, 1 in 1,000, if you think about it this way, 1 in 700 is about the rate of a Down syndrome, depending on the age of the mother. So 1 in 1,000 is not that off. There's 100,000 people in Prescott, 10 of you should die, eeny, meeny, miny, mo. You get the message. This paper is, where is it from? It's associating the increase in mortality after myocardial infarction. Basically what they've done is they looked at restrictive transfusion versus liberal transfusion in a heart attack setting. And actually what they find is people do worse. And the funny thing is when I was in Jersey doing my training, you used to transfuse because the heart needed oxygen, right? That was the sophism or the idea behind it. And the reality is people do worse. This paper is from Gut, 2011, and it's talking about, I think Mark already talked about it, so I can't really go in that one. He spoiled it. So we'll just skip that one. This is from trauma. Spencer already talked about it, so I guess I'll skip it. But the short of it is people even with trauma in the CRASH 2 trial did worse with liberal blood transfusion. And part of it is that the body's already in overdrive, and then you're adding something that's going to suppress that immune system. So they fall prey to an awful lot of other things. Death is one of them. This is from vascular surgery. After revascularization, the same thing. People tend to do worse if they're getting blood transfusions than not. This is from blood, and this is on, this was actually, I got this paper for this graph, and it has a bunch of complications. This is a complication from getting a blood transfusion where your lungs get stiff and you can't oxygenate. You can intrinsically die from that, and you need to be on a ventilator. This is the immunosuppressive state. You can have the blood actually attack you. I love taco. What it is you get a lot of volume, but you'll understand there's a certain soft spot in my heart about it. Of course, the immediate reaction, and this is a comparison between the United States and the UK, and this is the percentage of patients that have those reported cases. So then when you start looking at all these complications that we'll see in the ICU, you'll see that by far the biggest one is the lung injury. In other words, your lungs will stiffen up to such an extent that oxygen cannot cross. Even sometimes when you're on a ventilator, it's not enough. So there's people that are so bad you have to put them on a heart and pump machine just like you would for open heart surgery and try to buy them time. And time, I mean, give or take a couple of weeks, a couple of months. So when you start looking at all those complications, these are not in your informed consent. And that's the point I'm trying to make. That a lot of these things are just as deadly, and they do happen, but a lot of the physicians and patients as well the flavor you'll get is, oh, he went for surgery, this happened, that happened, and now he needed another blood transfusion, now his heart's not working, and nobody has ever really put the two and two together and realized that there is a correlation, and people truly do poorly. The dark side of transfusions, of course, you can just drop dead immediately. It doesn't happen very often. And for patients with cancer, they're getting constantly transfusions, especially those that the chemotherapy is destroying their bone marrow and things like that. Every time you throw a new transfusion, your body will learn the trick. And even though you're matching it, it'll make antibodies, and it'll defend itself against those new cells. So you decrease the chances actually of when you actually need it, get the blood, because you'll have made so many antibodies that they cannot match you. That is something that we deal with too, and then you die. So there's extra points if somebody can understand this. I like to speak in pictures. So what is the reality of it all? I mean, is it all that bad, really? Or is it a lovely picnic? And I think, I'm not trying to make this a relative issue. I did 7 years of philosophy, and I don't want to dwell on that. Is it a chicken or the egg? The point of it is you have to see the picture as a whole. So when you're seeing the patient, it's not about the blood count. It's not about the 7 or the 8 or the 9 or the 11. It's about what's the whole picture, what's the insult, what's the mechanism of injury, what is the thing you're going to do, what are their chances of survival, not just the count itself. So when you look at the alternatives, we've been working on alternatives for a long time for blood transfusions. We started with sheep milk and other things. In Germany, of course, they started with beer and wine. That is still an ongoing trial. We're waiting the results. We discovered that saline sort of helps. It expands the volume. You will have sort of a 3-to-1 ratio at which we can play, and we do. We've been researching, and by we, I'm putting myself there because I have nothing to do with it. 7 years we've been looking at making blood substitutes. They're really not working. There's some places in Africa and Europe that they use them, but they're not ready for prime time for many technical reasons. The reality is, where this leaves you with is, when you look at blood transfusion, you really are missing on the bigger part of the point and the bigger part of the issue, which is this should be a comprehensive team approach. So for me, it's a pleasure when I see that Pierre is on call, that Mark is on call, even Spencer, because they understand what it's really about. Sometimes I'll have a patient and Mark's already there before I can even get to him, and he's already scoped them. That's the kind of patient, the doctor that you want, somebody that will get to it and stop the blood before it starts. Nutritional support, even though we live in America, God bless America, we're actually a nation that's malnourished, especially as we age, ridiculously malnourished. A lot of our chronic anemias are nutritional. So in the hospital, sometimes we have to deal with those things and quickly, and we do. Bone marrow stimulants, it's a little bit like bullying, but with a license. So you can tell the bone marrow to work. Certainly comprehensive workup would need be. And you've already, if you followed the point and not just gotten hooked on the jokes, understood that it makes you sometimes arise to awkward situations. Perhaps when you start realizing that you started out with a lower health reserve, your chances of making it are not going to be that great because you got chopped in half. And that's just intrinsically bad, regardless of how much blood transfusions you get. And that makes us uncomfortable. And doctors have a hard time talking about end of life. Patients don't want to hear about end of life. But unfortunately, I will never run away from it because I could take the easy way out, give you a blood transfusion, you'll die anyway, and you'll think I'm great. Did I really do you a service? Not really. This actually puts us in this whole idea of, is the care you're getting truly critical care, or is it futile care? Am I doing it just because I can, just because I don't want to deal with you, or your questions from Wikipedia? Please do not Google Wikipedia. And it also puts us with, should we be talking palliative care instead of critical care? Maybe you're that sick. Maybe your body is truly shutting down, and I cannot stop that. Last time I checked, the guy that parted the seas wasn't me. So these are tough because I have to deal with your emotions and your expectations, but unfortunately, I will never choose to compromise over taking the easy way out. So the take-home message, can anybody guess what it is? That's a cute teddy bear. No? Blood transfusions are not cute. Blood is an organ, and this amounts us to having a small heart attack and demanding a new heart because you're unhappy with what you got. Well, sorry, it's not going to happen. Peter's not going to do it, and I would not bless on it. So historically, blood transfusions have been abused, over-glorified, to my personal opinion. Very little in the literature as far as benefit. Trust me, if you're bleeding out, we need to buy time. We can do it, but there's a price to be paid, and this is the balancing act. Can this patient take on all these risks? Can he tolerate if his lungs get stiff? Can he tolerate if he gets an infection? That's the real conversation that you should be having. And if the answer is no, then the question is it really that safe? It can be life-saving, but the reality is in most of the literature, it really doesn't show that it's working that well. If you have any questions, please ask. Not me, any of the experts. I was going to put a video, but I'm really illiterate, and I was not able to do it. So I will show you. In the video, you see how the cells are just whizzing through here, and here they're super slow. And you can find it in this website, which is bloodmanagement.com. They have that video. If you go home, do your homework, please. And that in a 2,000-word essay on what you've learned tonight, I'd be expected on Monday on my office. But if you click in there, you will actually see that video, and you'll see why actually blood transfusions really don't even improve that whole issue of oxygenation that much. Right now in critical care, we're looking at if the age of the blood makes a difference. It doesn't. The people that are going to die are still going to die. And I'll leave you with a pretty picture since I've spent most of the time talking about negative things. This is actually a local artist who knew that I was, my background, I'm part Spaniard, so he put a Quixote on his own rendition of the sunset from Van Gogh, but he did it with the background of Jerome. And he was able to actually replicate some of the textures and things like that. It was very touching. So please support your local artists. They may look weird, but you know what? There's something to it. Whoops, that's not me. Anyway, thank you very much for your attention.